welcome. I want to welcome the panelists here. We've got today Donna Dimitrovic from SAMHSA, Senior Advisor. We've also got Dr. Grant Baldwin from the Center for Disease Control, who's joined us. He's the Director of the Division of Overdose Prevention, and also Dr. Mary Hyde, who's the Director of Research and Evaluation at AmeriCorps. So thank you very much for being here today. We're going to cover some ground today. We want to talk about how federal agencies can take a demonstration project, expand it. We'd like to talk about some of the challenges that you face providing competent care to a nation that marginalizes people. We want to hear what do we need to know about recovery community support programs? How can they interface with the government? We want to know about funding issues, barriers to funding. We want to hear about recovery ready nations. This is in the drug control strategy, and how can we achieve that? What does that mean to your agency? So let's get started. Take it from the top. And I'm just going to I'm going to throw some questions out there, and I just want anybody to go ahead and participate as you see fit. But I want to start with how federal agencies can take a demonstration project and expand it so that everybody can benefit from the key learnings.
Thanks, Corey. It's a pleasure to be here today, too. As I was thinking about some of this, what comes to my mind is our CCBHCs, which started out as a demonstration project. And it was written into law, and there were certain criteria that we needed to have for people to participate as a CCBHC, which is a certified community behavioral health clinic. For those of you that don't know what that is, but so the 6 areas that it fell into was staffing, availability and accessibility of services, care coordination, scope of services, quality and other reporting, and organizational authority. So it really provided an opportunity in these demonstration projects for states to improve the behavioral health system. And a component of that was peer recovery support services, right? So while it may have been focused more mental health, it also included co-occurring disorders and substance use disorder. So that project, what I know about it, every year we do a report, and so there's findings and recommendations that are available within this report. And over the years, as it's moved into different iterations of the project, right now we have more than 450 CCBHCs that are operating in 42 states, plus in Guam. And so, states are really implementing the model. I think it's similar to like value-based or alternative payment methods, where states can do a state plan amendment for Medicaid waiver. But I think it's one of the, for me, as I look back at some of the things that SAMHSA has done over the years, it really has been a focus of a demonstration project that has really expanded across the state, and I think has made a huge impact for people in or seeking recovery.
I can go next. Again, as Donna said, it's certainly a pleasure for me to be here and represent the Centers for Disease Control and Prevention. I think for us, the way we bring demonstration projects to scale is very intentionally investing in them. So one of my colleagues came up with this moniker of adoption acceleration, which is a frame about how do you take evidence-based programs that are happening in communities and understand them better, and then ultimately bring them to scale. And one of the avenues by which we're actually making those investments come to pass is through a program called Combating Overdose Through Community Level Intervention. It initially focused specifically just on opioids, but the name changed. We took out an O, and we are now focusing on stimulants as well. These are small investments in communities across the country alongside our colleagues at ONDCP in the high intensity drug trafficking areas, where we're investing in exactly that. What is working in communities, post-overdose outreach, pre-arrest diversion, recovery support services? How can we, sort of identify what those programs are, evaluate their success, and then ultimately marry what is happening in the KUCLI program and bridge it into some of our other large-scale investments. CDC's One of our two flagship investments from the Division of Overdose Prevention is a program called Overdose Data to Action. Funds 47 states, 16 big cities and counties, DC, and 2 territories to sort of have data inform action. And it's in that action phase that we can implement some of these evidence-based programming. That program is going to, we're going to sunset the first OD2A 1.0 next August, and then we're in the process of reimagining what that program might look like going forward. But it's a huge investment, $300 million a year. In the current version, and I anticipate something similar going to be happening moving forward, we give states a ton of flexibility to say, actually, we want to work in these high-risk areas and communities, and we want to do these certain evidence-based interventions. So there are obviously requirements of the program, but a ton of flexibility is built in. And the last thing that came to mind with the question, and I'll put it in the chat, we just released what we call a technical package on linkage to care. This is parlance that dates back to previous CDC director, Dr. Tom Frieden, who said, what if we put together a resource where we compiled, this is what we know works. What you need to do is take this evidence-based, tailor it, customize it, make sure it's culturally appropriate, that you could potentially implement in your community. And so a team of people here at CDC and in other places just put together this linkage to care technical package. I love these documents. It's absolutely fabulous. And I suspect participants on this webinar will as well.
Right. Thank you. Thank you.
I'll just add to what Donna and Grant have said. I don't know that my answer is a direct response to taking demonstration projects to scale, but I want to latch on to a word that Dr. Baldwin used, and that's accelerator. So for those who are not familiar, perhaps with AmeriCorps as a federal agency, we have a mission of strengthening the civic and community life of local communities across the country. So all of our investments go into state and local cores, National Service Program cores. And so these cores are one way to take all of the research-based, evidence-based practice that is under discussion today with all of the great panels that have been going on today, taking that practice and making it available to more folks, typically in underserved and perhaps marginalized and under-resourced communities. So we have, for example, recovery cores, we have housing cores, and one of the things that we really focus on is building those resiliencies, not only within individuals as they, take seriously their civic life participation and serving in these cores, but also the resiliency of communities. And, advancing a recovery-ready nation, I think you really have to think about the communities in which folks who have substance use disorders are trying to live their lives and are returning to their lives perhaps after periods of treatment. So I would say that this is the way in which our federal agency contributes to these goals. Perhaps not a demonstration project replication, but we are very much taking the evidence-based research and the findings that many of the esteemed folks have been talking about in this summit, combining them into cores and deploying cores of individuals across the country to help folks with their recovery journey.
Thank you, Dr. Hyde. Great. I want to move on to, I would like to hear from you regarding how you deal with the challenge of providing competent care to a nation that marginalizes people who have used a substance, regardless if they have a substance use disorder or not. So.
I'll just jump in and say that I think one of the ways that our investments in this space and in our programs address what you're asking about is, taking value and showing value in the lived experience. So for example, in the recovery cores that we invest in, the national service participants who are serving as peer recovery coaches have lived experience with this. And in addition to the research-based practice, they're combining that lived experience. So I think, member by member, those who are serving others who are in their recovery journey, you start to destigmatize and you start to create service in communities that typically perhaps are marginalized, including, the very communities in which our programming serves. So I think this is one way in which you can help address that by encouraging, and again, these are non-clinical, this is a non-clinical, a strategy. I'm not saying that this is a clinical strategy, but in the non-clinical world, I think this is a way that you get everyday citizens to understand this issue and to, in a civic duty sense, take this space and serve their fellow community residents. That's, I think, how we do it.
Yeah, I'll go next and build off what Mary said. I mean, I think one of the biggest things we're doing, as she hinted at right at the end of her, and I think all of us are doing it together, is working on issues associated with stigma. So last September, CDC put out 4 mini campaigns on fentanyl, naloxone, polysubstance use, and one intentionally focused on stigma. And we've had, obviously the health communication scientists that I have working for me went through a very rigorous process in developing those campaigns and formatively testing them. And we've got massive uptake. So just in 2022 alone, we've got about 1.3 billion impressions on those campaigns, including almost 610,000 people who've actually gone to our website and clicked on content, which is, in my mind, very, very impressive. And I think there's broader efforts that CDC is partnering with other organizations to continue to amplify issues around stigma, to make sure that folks who may be marginalized now because of their substance use are no longer marginalized moving forward. But I would also say, when I first heard the question, it sort of raises the issue more broadly around equity. And CDC, like other federal agencies, we're thinking a lot more intentionally about how we can better address issues of health equity. So we have core health equity goals. All of the investments that CDC is going to have moving forward will have a health equity lens to them. We have a health equity style guide as a very specific, tangible example. Sort of the words matter, and how you say things matter, and how you say things and even notice of funding opportunities matter. So you'll see a focus on disproportionately impacted and marginalized populations moving forward, not just in our program investments, but also in our research investments. CDC, unlike our colleagues at NIDA and elsewhere, we're very focused and very intentionally, because of our smaller portfolio, on applied research. So that applied research will have a disproportionately impacted focal point to it.
So I would just add too, with SAMHSA, as Grant was talking about, as CDC, we have really elevated our Office of Behavioral Health Equity. And as most of you know, this administration, that's an important topic and things that, we really need to be focused on as we move forward. With our newly established Office of Recovery, I really feel like our Office of Behavioral Health Equity and the Office of Recovery, we do work hand in hand, because I think you can't have one without the other, right? Because we do face a lot of stigma, discrimination as people in recovery. And so, some of the key strategies, not only working with underserved racial and ethnic minorities, but, also looking at LGBTQ populations. The Office of Behavioral Health Equity looks at data strategy, policy strategy, practice, and workforce development and communications. And through that office, we've helped to establish the national network to eliminate disparities in behavioral health. And so we do a lot of training and technical assistance towards the goal of promoting behavioral health. And also another initiative under OBHE or OB is the are elevating community-based organizations. And I'm a firm believer that, well, number one, all the work happens in communities, right? But we really need to help support those local, really small community-based organizations too, because, at the end of the day, they're doing all the work. And so we want to help them build capacity and increase their visibility. Looking at the underserved and marginalized communities, that's what we do, not only through our Office of Recovery, but also with the Office of Behavioral Health.
Mm-hmm. Right. And just tying together a few of the things that were mentioned here, we talked about equity, and discrimination was mentioned as well. And, discrimination is the function of being part of a marginalized group. And certainly in the field of recovery and addiction, we've actually built in structural discriminations that were allowed, not allowing people to get access to a Pell Grant to further their education, a lifetime ban on nutritional assistance, ban from voting, and things along that line. And these kind of structural components are the ones that disproportionately impact the people of color. And so that kind of tying that all together there. Thank you very much too. I want to know about, what can you tell us about what we should know about recovery community support programs, and how can they interface with other government offices to bring care to people who are in need of recovery?
So I can start with that, since SAMHSA was the originator, I think, of the Recovery Community Services Program back in 1998, and I was actually honored to be one of the first executive directors of that grant program back then. So, it really did provide an opportunity, number one, to provide a face and a voice to people in recovery, family members, because I know early on when I was doing work in Pennsylvania, policymakers were like, we don't know anyone in recovery. So it gave us the opportunity to kind of highlight the faces and voices of recovery, but it also really helped to provide peer recovery support services through community-based organizations, or recovery community organizations as we know them, or recovery community centers, for not only individuals with substance use disorders, but also those that had co-occurring disorders. And really the foundation of that program has been the lived experience of people to really help others in achieving and maintaining their recovery. And so these services through the RCSP can be in conjunction with clinical treatment centers, services, and are also really an integral part of the recovery process. Like I said, I think it really elevated the voice of people in recovery. It gave us a little bit of a validation, I guess, to our own recovery stories, but also, that what we had to say was worthwhile. And as I was thinking about this, of course, I was thinking about Bill White, who's a well-known historian, and he talks about what emerged as the new recovery advocacy movement was much broader than the programs that were funded, but they were among the strongest and most effective of the newly formed recovery community organizations. So I think it is an opportunity for people in recovery to be connected with policymakers, both at the local, county, and state and national level, that probably we hadn't seen before then.
I can go next. I think what, CDC obviously works very closely with our partners at SAMHSA, and we see ourselves as a bridge to some of the services that SAMHSA and others within states and localities provide. So one specific example, going back to overdose aided action, is a greater investment in linkage to care, which, again, I'm anticipating that investment on linkage is going to grow. And, obviously as we've talked about throughout our time together, the importance of ancillary services and supports that can keep people in long-term and sustained recovery. The other point, it's a little bit askew, but I think it's relevant here in terms of a CDC investment that has a connection. We are investing in what are called FAST teams. These are public health and safety teams. It sort of builds off what it was initially done in New York with their RxStat program, where you get sort of broad stakeholder involvement coming together to look at a couple of things. One, a small set of very specific case examples of somebody who a decedent from an overdose, but then obviously at very broad trends in the area. What I love about the idea and the model is it says basically, where are the gaps in service delivery? Where were there opportunities that were missed to get people to connected and to be able to stay in their services that they would need? But not in a kind of accusatory kind of like hard hitting, but just like, we need to do better, guys. We've got to do better. How do we, as we all agree on this goal of needing to reduce overdose deaths and get people sustained in long-term recovery, how can we come together to do that? So it's a model that we've piloted in 10 states and are looking to grow further. It's a little bit akin to overdose fatality reviews with a little bit of a twist on it, which I really like. And I think it bridges over to the recovery community support program frame. Over.
Well, I'd like to ask the panelists next, what do federal agencies need to provide the necessary funding? I'd also like to hear from you regarding what's hindered the funding process as well in your experience.
I could start. I mean, I think, obviously one of the biggest things that has hindered our process recently is the COVID-19 pandemic. We have really, in the major investments that I've talked about, we have some jurisdictions with significantly large amounts of unobligated dollars, not by not wanting to do things, but because of, the same staff person who is leading the state level drug overdose prevention activities was now tapped in to do some leadership on the state COVID response. And so there's an unfortunate reality of sort of dealing with two crises at the same time with the COVID-19 pandemic and then the drug crisis. But then I would also say one of the other things that's hindered us is sort of needing to think creatively about how we can make sure that our funded jurisdictions can get the money out to where it's needed most, and looking for flexibilities and supporting states and being able to do the hiring that they need to do. Let me give you one specific example. We just started working with a philanthropic arm of CDC called the CDC Foundation, where states can invest in the CDC Foundation to provide staffing support. One specific example that I think will resonate with the group is that allows them to hire individuals with lived experience. I am hopeful for all of us that will be less of a challenge moving forward. But right now, putting somebody on the state health department roles has been a challenge. But leveraging this creative mechanism allows them to hire both more efficiently and people with the skills and experiences that they might need. So those are a couple of the hindrances: the COVID-19 pandemic, and then some of the realities of doing state and local health department based activities. Over.
I would build on those ideas and say that obviously COVID was challenging in many ways, but certainly we noticed even with our investments, which in 2021 were about 41 million, and in 2022 with our partnership with the CDC, with Public Health AmeriCorps, about $8 million has been invested in the issue of opioid use disorder and substance use disorder. But COVID disrupted our ability at the very local level to deliver these services. So some of that funding was unexpended because peers could not get to folks that they were working with in recovery. So there was just a disruption in services, and the recovery coach model is very much an interpersonal face-to-face type of model. So COVID disrupted the ability to do that. But I want to pick up on another, I think, important idea that Grant raised here, and that is getting money into communities is all about the right relationships, right? Like, so sitting from a federal agency perspective, you have to have the right relationships in the public health community and other communities to understand how to get that money into the right hands, into the right communities with the most need. And I will just add that, with the Public Health AmeriCorps initiative, that, part of the goal of that work is to rebuild capacity in the systems that, are in communities to help with the recovery process. So I think that's some ways in which, our agency, and again, in partnership with the CDC for Public Health AmeriCorps, is really working to strengthen and rebuild those state, local, and federal partnerships that are essential for getting those funds into the communities that need them most around this particular issue. So that's how we're thinking about it anyway.
Yeah. From a scientific perspective as a researcher, and I think about the facility, the hindrances on the funding process. I think about any needing to know what the research questions are that will help facilitate people in the federal offices to decide where the money goes, specifically, this breakdown between recovery support services and treatment. And right now we don't have enough science in that area. It is developing, it is building. Not everybody, for example, will be willing to take the medication for opioid use disorder despite its larger effect sizes. We need to understand that those effect sizes need to also be trialed against frontline medications relative to sober homes. These are powerful effects in this body of literature, and this is how we create pathways to recovery. And so looking at the knowledge gaps as well, that are barriers to the people who are working in the federal agencies, trying to build the infrastructure for the United States as well.
If I could just add, one of the things as we were talking about this question that came to mind that I neglected to mention in my comments was, as part of, a lot of folks on the webinar have probably heard about CDC's effort for moving forward and how we can learn from, some of the missteps associated with the COVID-19 response. And one specific example that it interfaces with our work in drug overdose prevention is associated with just how jurisdictions apply for CDC funds and the challenge associated with applying for dollars and the complexity of it. So obviously, as Americans ourselves, we want fiscal stewardship, but we also need an ability for folks to access resources in a way that it doesn't require a PhD for you to be able to actually submit the application for funding. Over.
Absolutely.
I would second that point.
Yes, and just from seeing some things on the ground, just and in service to some recovery community centers and organizations, some needs along the line of that, you actually have to have the money first, and it's a reimbursement system a lot of the time. So it's whoever has the money gets the money, and you've got to figure out how to float that. All these details and how and that really underlie the process. So Recovery Ready Nation, this is a term that's out there. It's in the National Drug Control Strategy, which is a big shift from what we've seen. What does that mean to you? How do we get there? And what's going on in your agencies with that focus on what a Recovery Ready Nation is?
So I can start on this. For me, really, I would envision that people could get whatever they want, when they want it, within their community and anywhere. And so, lofty goals, stigma, and discrimination wouldn't exist, right? And really, like Gran and both Mary were talking about, like organizations wouldn't have to position themselves for funding opportunities. So it's like, everyone is trying to vie for the same funding. Now, of course, in reality, we know there's never going to be enough money to go around, right? So how would, one of the things that I think about, and I think prevention does a really good job of collaboration in communities. So from the community standpoint, individual community, system level, if everyone would collaborate and work together, I think we could become a recovery ready nation. It probably would take some time, but I know for SAMHSA, we really have, of course, the establishment of our Office of Recovery, and we've really done a priority of ours is really to connect with both internal and external stakeholders. So working with federal partners is, like the CDC, like AmeriCorps, like ONDCP, that maybe, those relationships have been on the back burner over the last couple of years, but being able to really connect and understand what everyone else is doing and how we can put together a strategy, with this end goal of a recovery ready nation. And so I really believe that we're stronger together, and we have so many smart great people out there that, we're all in it for the same reason. So people don't die and families don't suffer, right? And so, if we can really put our heads together and figure out how to collaborate, I think we could have, a recovery ready nation. But it's there's so much involved. It's going to take some time, but I'm confident. I don't know if it'll be in my lifetime, but I'm confident.
I would agree. I actually think I would like to share just a little bit of evidence that we have to back up Donna's point there on collaboration. I mean, not only is it important for a recovery ready nation to have collaboration at the federal level across the agencies that we represent, but we have actually sponsored some research using Dr. Zimmerman's SEED method in Martinsville and in Minneapolis. And it is a methodology that is research-based, and it is used, it's a community stakeholder method where every sector of a community is brought around together to address a health issue. And it combines getting community members to identify the critical research question, but also the critical action plan. And we funded this in Martinsville when they wanted to take on the opioid use disorder that was facing their community. And fast forward a few years, using this methodology, the SEED method, they have come together as a community, identified that a drug court was one of the key things they needed to respond to this issue in their community, as well as some other recovery support services. They took this idea in Minneapolis as well, because there's a very active community there, especially in the national service space, that is taking on this issue. And they have used the same methodology, again, to bring different community sectors together, whether it's law enforcement, whether it's families who've been affected by this, whether it's, persons in recovery, whether it's the behavioral health system. All of these key stakeholders are brought together in a very intentional, methodical way to sort through data, to sort through the research, to sort through what might be a viable solution. And then they agree on the priority for their community and how they're going to address this. And then they identify the action steps needed to garner the resources and the will to make it happen. So very small scale, but we have seen that work. And I think there is evidence to support Donna's point that collaboration is essential at all levels to make this a viable and a recovery ready nation.
Yeah, I agree with everything that's said. I think what I would add that hasn't been said already is just recovery ready also, it's not just connecting public health and behavioral health and clinical medicine, it's bridging in some of those ancillary services and support. So housing and transportation, which we hear often about, employment support as a specific example. So it's really whole person mindset around what recovery looks like. The other thing that hasn't been talked about yet that I think is, in my mind, part of a recovery ready nation frame is for the first time, the National Drug Control Strategy includes a focus on harm reduction. And I think we need to invest more and more in harm reduction, given the illicit marketplace right now. That harm reduction, with naloxone saturation, fentanyl test strips, syringe service programs, et cetera, those efforts need to be amplified in creative ways, mobile outreach, all kinds of venues and avenues that we know from research and from the evidence base can really support people in their long-term recovery. So that's part of what the harm reduction is part of what a recovery ready nation looks like to me as well. Over.
Excellent, thank you. Yeah, I'd like to move on. Thank you. Who else can help fund the development of recovery services, and in what ways? I know Dr. Baldwin had mentioned a little bit about the philanthropic community. What are you seeing? What are you seeing out there?
I'll start. I talked about the CDC Foundation as a central arm of, doing things that CDC can't in ways and with efficiencies that we also can't, which is critically important. But we're working with other philanthropies as well. I'll specifically call out Bloomberg Philanthropies. Some of the FAST work that I mentioned earlier is supported by Bloomberg Philanthropies. So these public, private, and philanthropic partnerships are really critical for us moving forward. In part, there's a couple of benefits to it. One, because of, adding resources to our ability to do more work, but also there's a push for innovation, and there's an even stronger emphasis on accountability that I think we all want, to make sure those dollars are used in the right kind of way. And there's a very intentional effort, even more so around, sort of targeting efforts to those at greatest need. So, besides the CDC Foundation, the other major avenue where CDC Beyond an increase in our congressional appropriation, which we continue to be grateful for over the last few years, which has allowed us to do more and do more differently and do more that's more broadly attentive to the scale and scope and diversity of the crisis, is some of these investments that we can make, or some of the supports that we can get from others like our philanthropic partners. Over.
I
Wow.
would just add that our funding model by design, all organizations that apply for AmeriCorps funding have a match requirement, and our agency, through various initiatives over the years, has required public-private partnerships, in the sense of, if we're giving you $1 million grant, you need to match at a certain level depending on various criteria. But I think the way in which we have set up the way in which we do grant making that requires this local match is one way to engage the philanthropic sector, the private sector, but particularly around the issue of recovery and being a recovery ready nation. I think that, the only way we're going to meet the need, I mean, everyone has been talking about it, this growing need, and to have these effective models and strategies and approaches get to a scale at which it can actually address the issue, it's going to require public-private partnership. Federal government is never alone going to have enough money to solve this issue. Private sector alone, it's going to require, again, this theme of collaboration. It's going to require, joint funding, threaded funding, and a very intentional type of partnership to take this on, I think, at a national level.
Well, Donna's getting back on, let me just also add, I think one other major activity all three of us have talked about, multi-sector collaboration. The partnership specifically between public health and public safety for us has been absolutely critical. I think our law enforcement colleagues are beginning to really recognize the need for the partnership with public health, and we have an overdose response strategy where we paired a public health analyst and a drug intelligence officer. It's now nationwide, so all 50 states, DC, Puerto Rico, USVI, et cetera. And those two individuals, the public health analyst and the drug intelligence officer, do data sharing, look to implement some evidence-based programs in the field, and do, frankly, going back to one of the earlier questions, look to see what works and ultimately to share it more broadly. So that, it's not a partnership necessarily with our philanthropies, but one where we, CDC, are going to continue to invest more because of the opportunities that exist in that partnership. Over.
So I would just agree with both Grant and Mary said. One of the things that I think about, though, as well, is that I think recovery community organizations and the recovery community needs to own getting the research, help to support the research that we need to validate the work that we're doing. And so, taking a more active role and being mindful of the fact that we need data and evaluation to really show how recovery and has a positive influence on the country, right? And so that's just one of the things that I often challenge the recovery community around, like, let's make this important. And I get that at the end of the day, everybody's worried about providing services, but we also have to have that information to move it forward. And, then it makes it easier to ask for financing and funding.
Yeah, I think that's another space where it is going to take both sectors. I mean, we too evaluate our programs, but it's at a relatively small scale. We're evaluating our recovery coach. The models are, showing outcomes, but at a local level, for those who have these programs at a local level, having private level funding to help offset those costs of the data that is needed to track these outcomes, to demonstrate the value of this work. It can't just be a federal effort, it can't just be a local effort, but you really do need that program evaluation data, that strong data that shows the patterns, that is really going to guide where we continue to invest resources. But it's an important piece, even though everyone feels the urge to direct it all to direct service, you actually do need the data to show the value.
And I came off mute because I wanted to flag for the group when Mary talked and Donna started talking about evaluation. I completely agree with what they said. We put together an evaluation team in my division, put together some profiles for some evidence-based interventions across the evaluation continuum, because the reason I thought of it when Mary was talking is sort of how do you make sure there's consistency and measurement across jurisdictions so that you can actually do an apples to apples comparison, which is really, really tricky. So during the break, I'll put the link in the chat to some of these profiles, which I think are really quite helpful. Over.
Thank you. Okay. So closing thoughts, remarks. Dr. Barthwell is back as well. Thank you. And I'll pass it off to you, Dr. Barthwell, time-wise, where are we at here?
Yeah, they actually have a couple minutes, so let's hear a closing thought from each of them before we go off screen.
Great.
Dr. Baldwin, Dmytryk, and Hyde.
Closing thoughts for me, I look forward to continuing conversations, particularly with Donna and Grant, given what I've learned from them today. And I think this summit is remarkable. And I hope, as others have said throughout, that this conversation continues, because I think it's conversations like this that will facilitate these connections and this idea sharing and access to what we all know and how we can do it better.
I mean, the closing thought for me is that it's a fundamental belief, I think, and maybe it was one of the reasons you asked the question, is that a recovery-ready nation is entirely possible. And the people who are responsible for that are everyone who's on this webinar. And so we all take a great degree of pride and responsibility and energy and lose plenty of sleep to figure out how to do that. But I continue to have a fundamental belief that can occur and will occur because of our persistence and our unwillingness to accept anything less.
Thank you.
I totally agree. And I just thank you for the opportunity to be here today. I think it really is an important topic, and I look forward to the Recovery Ready Nation as well. So thanks a lot.
All right, well, thank you all.